Hello everyone, and a warm welcome to Clinical Pharma Easy, the channel that provides simplified and easy-to-grasp knowledge on clinical pharmacology. Today, we'll be discussing the Global Initiative for Asthma, GINA, Guideline for Asthma Management. The GINA guideline is an evidence-based approach to managing asthma that provides a structured approach for healthcare providers to assess, treat, and monitor patients with asthma. In this video, we'll explore how to assess the severity of asthma, the stepwise method for managing it, and treatment options for patients at varying levels of severity. Mainstay of asthma management is inhalers. The choice of inhaler device depends on various factors such as the patient's age, dexterity, inspiratory flow rate. Metered dose inhalers, MDIs, require coordination between the patient's inhalation and actuation of the device to ensure that the medication is delivered to the lungs. MDIs are suitable for patients who can generate an adequate inspiratory flow rate and have good hand-breath coordination. Spacers are devices that attach to the MDI and hold the medication until the patient is ready to inhale. They provide a longer time frame for the patient to inhale the medication and can reduce the amount of drug deposited in the mouth and throat. Spacers are beneficial for patients who have difficulty coordinating their inhalation with MDI press, such as children or the elderly. Dry powder inhalers, DPIs, do not require coordination between actuation and inhalation and are breath activated. They are suitable for patients who have difficulties with MDI coordination or those who have low inspiratory flow rates. The first step in managing asthma is to assess its severity and control. This involves a comprehensive evaluation of the patient's symptoms, lung function using peak expiratory flow rate, PEFR, and history of asthma exacerbations. Once this is done, there are two ways to go about treatment. The first method involves using two different inhalers for relief and symptom control, while the second method involves using a steroid formoterol combination inhaler for both relief and symptom control. The two-inhaler method has the following steps. Step 1. Intermittent asthma. Patients with mild, infrequent asthma symptoms less than twice a week and no impairment in daily activities can be treated with a short-acting beta agonist, SABA, like MDI salbutamol 100 microgram per puff or DPI 200 microgram per capsule for quick relief of symptoms. Step 2. Mild persistent asthma. Patients with symptoms more than twice a week but not daily, and some impact on their daily activities, can be treated with a low-dose inhaled corticosteroid like MDI betamethasone 80 microgram per puff twice daily or DPI 200 microgram per capsule daily as a controller medication, along with a short-acting beta agonist for quick relief. Step 3. Moderate persistent asthma. Patients with daily symptoms and some limitation in their daily activities can be treated with a low-dose inhaled steroid and long-acting beta agonist like fluticasone salmeterol 45 by 21 micrograms 2 inhalations twice daily, along with a short-acting beta agonist for quick relief. Step 4. Severe persistent asthma. Patients with frequent daily symptoms and significant limitation in their daily activities can be treated with a high-dose inhaled steroid plus a long-acting beta agonist like fluticasone salmeterol 230 by 21 micrograms, 2 puffs twice a day, or DPI fluticasone salmeterol 250 capsule, 2 capsules twice daily, along with a short-acting beta agonist for quick relief. Method 2. One inhaler method. One inhaler method is a newer approach for managing asthma, which uses a single inhaler for both symptom relief and prevention. This inhaler should specifically contain formoterol with a steroid. From intermittent to mild persistent asthma, this is step 1 and 2 in two-inhaler method. The patient uses the inhaler as needed whenever they experience symptoms. The recommended dosage is 1 puff of MDI budesonide formoterol 200 by 6 micrograms. This inhaler acts as both a reliever and a preventer, providing quick relief from symptoms while also preventing future attacks. Step 3. For moderate persistent asthma, the patient uses the inhaler as a maintenance medication twice a day, in addition to using it for symptom relief as needed. The recommended dosage for maintenance is 2 puffs of MDI budesonide formoterol 200 by 6 micrograms twice daily, and 1 puff whenever symptoms occur. Step 4. For severe persistent asthma, the patient uses a medium dose of steroid and formoterol for maintenance, in addition to using a lower dose for symptom relief as needed. The recommended dosage for maintenance is 4 puffs of MDI budesonide formoterol 200 by 6 micrograms twice daily, and 1 puff whenever symptoms occur. It is important to note that the maximum dose of formoterol that can be given in MDI budesonide formoterol is 72 micrograms, and exceeding this limit can cause adverse effects. Step 5. The management of severe persistent asthma is similar in both 1 and 2 inhaler methods. Patients are treated with a high-dose inhaled steroids and long-acting beta-agonist plus muscarinic antagonist like biclometasone formoterol glycopyrronium combination inhaler 87 to 5 to 9 micrograms twice daily, MDI budesonide formoterol 200 by 6 micrograms 1 puff for symptom relief. Azithromycin 500 mg 3 times a week and low-dose oral corticosteroids less than 7.5 mg per day should be considered. If facilities are available, phenotype assessment and targeted biologic agents could be used. Other therapies that may help include vaccination for influenza and pneumococcal, immunotherapy, bronchial thermoplasty, vitamin D supplementation. Aminophylline and theophylline are not recommended due to side effects, while leukotriene receptor antagonists have limited evidence. It's important to note that the steps in the GINA guidelines are not rigid, and patients need continuous monitoring for symptoms, side effects, frequency of exacerbations, and lung function. Inhaler technique, comorbidities, and modifiable risk factors should also be reassessed and adjusted based on individual patient needs and response to treatment. The goal of treatment is to achieve and maintain asthma control with the lowest effective dose of medication. If you found this video to be informative and helpful, please support by liking and subscribing to my channel. Your engagement will help me create more educational content like this. If you have any questions or feedback, please leave a comment below. I will be happy to hear from you and respond to your inquiries.